So I want to now introduce our presenter for today. This is Dr. Hermann. He is our chief fellow here at Stanford Chronic Pain Management Center. He completed his residency at the University of Michigan in radiology. And then he completed part of his residency and physician training at one of the largest prison facilities in the country, treating inmates there. And like I said, he is our current chief fellow here. So without further ado, I'd like to give the microphone over to Dr. Hermann, and I will start the recording now.
All right. Thanks, David. So thanks, guys, for coming out. I just wanted to talk about the importance of social support in pain. It's something that I kind of saw a little bit in my residency training and in fellowship. So does anybody know what the biopsychosocial model means? Just in essence, it's just a model where you have this Venn diagram. Psychologists love to use it because there's different aspects that you can play off of. But we always, in medicine, I feel like the biggest emphasis we have are on psychological and biological. Mainly biological, or like, let's say that your blood pressure's high, you treat it with a blood pressure medicine and it goes down. But then there's some health aspects where it's biological and psychological, like endogenous depression, where your body just does not just secrete maybe enough dopamine, and that all interplays with biology too. But then the part of this Venn diagram that's most overlooked is actually the social aspect. So let's just go into that, if you'll let me. Okay. So whenever there's a health illness, there can be different contributing factors. One thing would be your genetics, mental, physical aspects. And then let's say psychological, you have anxiety or depression or stress or coping, it depends on your coping skills. This is actually where coping skills comes in, whether they're passive, such as catastrophizing, or active. And then social, the most overlooked part of the Venn diagram includes spouse, family, community, work, school, culture, religion. These are just some examples. Let's say that you have like a hobby or activity, the people you meet through that. And it actually has been correlated in research with better outcomes in pain. So all these actually interplay. Some of these can be kind of like a gray zone. Something may be social or biological, but something else may be psychological or biological. But this is the most overlooked part of the pain experience. Chronic pain can lead to decreased social interactions. And that can be kind of like I guess you could call it a vicious cycle, to where once you have decreased social interactions, your pain gets worse, which leads to more decreased social interactions, and round it goes, which also can go to the, I guess you could also say it goes to the psychological aspect, where more pain can cause more depression, which causes more pain as well. And then the biology of it is, you could just take that whole Venn diagram in every aspect. And you can even read it on the slide. So chronic pain can lead to decreased social interactions with mood. It can actually increase your anxiety just being alone. Decreased ability to engage. Your cognitive bandwidth, that's another concept they use in the literature, decreases, and you're less likely and have less energy to go out and have social interactions. Fear avoidance. So let's say that you like to play volleyball, but you injured your back, and this would cause more avoidance in your activities, which is another vicious cycle I talk about in the clinic almost with every patient. A lot of people with pain have embarrassment or shame, especially when it comes to opioids. The first thing people say when they're on opioids is, I'm not an addict. And a lot of times with chronic pain, when you have decreased social interactions, you have more shame and embarrassment, not just with the conditions and the medications that you're prescribed, but also with the fact that you have this painful condition. You're embarrassed that you're not able to go out, or that you're just, some people, the way they view themselves, the words I hear them use are pretty negative. In terms of uncertainty how a condition can be received, the problem with pain too is that you can't see it a lot of the times. So let's say that you have like a tumor or something, you can feel it, you can see it. But with pain, sometimes maybe the injury is healed and there's no signs of injury anymore, but it's still there. So what happens is sometimes people can be depressed and have decreased social interaction because they don't receive it well. So patients often face skepticism about their condition. That is something I see a lot where people say people think I'm crazy when they actually have a real diagnosed condition. 20 years ago, chronic regional pain syndrome was kind of in that bucket where even providers didn't see them as having a real condition. Side effects, so gabapentin, Cymbalta can cause sometimes people to be sleepier and then they're less likely to go outside. So the true definition of social support that I believe is that it compromises the social resources that people perceive to be available or that are provided within the context of informal or formal relationships. So this definitely directly affects health. The number one predictor of decreased life expectancy in a male, which is decreased by 10 years, is actually being alone, not being with a spouse. This has been seen in other dimensions of the, in terms of health and life expectancy. It does there's lower levels of pain-related disability, and lower social support skills inhibits your ability to go out and do social activities. And let's say you have a stressful event or some sort of buffer. If you don't have a support system like a good family or a wife or anybody around you, it doesn't have to be relatives. The research has shown over and over again this doesn't help out. So social factors, interestingly enough, can actually be a negative thing where it increases the vulnerability to experience chronic pain. So there's a thing in the, or concept in the psychological literature called ACEs, or adverse childhood events. That's one of the biggest risk factors actually for chronic pain. Interestingly enough, people who have adverse childhood events, 15% of them can be described as resilient. Some factors that can increase resilience to chronic pain, which means they're able to bounce back really quickly. Positive emotional states or meaningful social ties. It's very counterintuitive, especially in Western medicine, where we think that pills one-to-one affect an outcome, but it's actually a lot muddier than that. Having a good social support, someone you can talk to, can decrease pain intensity, or someone just to express your pain to actually can help out. So this is a concept that even I had to learn, is that pain could be a social phenomenon. 5 decades of research has shown that psychology can affect pain. 3 decades of research, probably about since maybe the late 70s, early 80s, has shown that social support affects pain and pain self-efficacy. Neurobiology, the strict definition is a connection between the pain and the social pain. So in that biopsychosocial model, that's the overlapping part of biology and psychology. So these are the things I've just discussed, such as ostracism, loss, conflict, rejection, and bereavement. There is a shared neuropathway demonstrating region of the brain associated with pain, distress, and social pain. So this was on functional MRI. I wouldn't get into the details of what a functional MRI is, but from a radiologist perspective, it's where they measure different levels of activity in your brain based on brain oxygenation. And these areas of your brain are actually not only associated with pain, but they're also associated with depression. The anterior cingulate cortex actually is involved with your emotional response to pain. So lack of social support actually affects this. So further studies, there's a study that I was reading that actually showed that if you're excluded, you feel like you're socially excluded and ostracized, that you can actually have similar levels of distress as having being put on a hot plate or whatnot. Daily ratings of loneliness are predictive of pain intensity. So when I see patients in the clinic who are at home and they're playing like World of Warcraft alone by themselves and not like going out and doing stuff and just getting some sunlight, it's not surprising to me that their levels of pain are higher and their levels of catastrophizing are higher, meaning that they can't stop thinking about their pain because they have no distraction, no friends, and they feel like their pain is consuming their life. And their self-efficacy is very low. Social stressors are related to pro-inflammatory cytokines like interleukin 1, 6, and 8 and TNF-alpha, which have correlated with pain intensity. So the same chemicals that are released when you cut your hand or have an injury are actually released also when you have social stressors, which means if you don't have a social support system, like, let's say you're having trouble making rent or you're having trouble paying your bills, same cytokines are released as when you're in pain. Genetic factors, we can go into that later, but some genetic factors can predict whether you might have resilience from adverse childhood events or not. They studied this in the veteran population, and it's also like this in pain. So my main takeaway I want you to get from this lecture is that it's not just that you experience a painful episode, like you injured your foot or you injured your hand or you were involved in like a car wreck and that affects your pain, and you go to the pain doctor and you ask the pain doctor, what can I do for you? It's actually this really muddy construct of biology, psychology with how you interpret the pain and your emotional response, which is one of the Kubler-Ross dimensions of pain. And then the last thing is social support. The gear in social support, it's bigger because it's super under-recognized. So perceived levels of dependence and codependence predicted higher levels of pain disability. So when people didn't feel like that, they were able to be independent based on their pain, surprisingly enough, their pain disability went higher. Does anybody know if you're injured in a workplace accident at 6 months, how many people return to work? Like what percentage? It's about 50. At a year, it's about 40. At 2 years, it's about 5. And the highest risk factor was actually, the biggest risk factor was actually poor social support. So if you're injured in a workplace accident and you go home and all you do is like watch Golden Girls and drink beer, your prediction for returning to work at 2 years is 1 in 20. So support from others can reinforce pain behavior. I'd like to actually look at that. So your support system, it's not just having a support system, but it's having one that maybe would reinforce the good behaviors that you have. In other words, if you're catastrophizing, if you have someone that just wants to reinforce that, you'll see it in the clinic where you have these, I don't know how else to say, but people reinforce the negative behaviors, and it's unsurprisingly, people don't get better. So fear avoidance is something I talk about in clinic all the time. Let's say that you hurt your shoulder or you hurt your neck or something, and you don't move that area. That's why we give physical therapy, because if you don't move the area, the muscles get tight, they hurt, and it's just this horrible vicious cycle. It's just one of those things I say every day in clinic. So that can actually be more disabling than the pain itself. So trying to figure out how to reconstruct your life to avoid the pain. Negative social support. So I think I've touched on this. It's not always just having people, and I don't think I need to go into that too much more. This is a kind of a busy slide, but the main takeaway I want you to get is that you have a physical pain dimension and you have the social pain dimension, which we never recognize in our medical system. It's interesting to me that both actually have the same outcomes with neural activation, affective states, which meaning your mood, cognitive behavioral responses, and social relationships. So everything in the social realm and the biological realm have the same outcomes. So if you have a history of physical pain or history of social pain in terms of like trauma, abuse as a kid, it actually can have the same neural pathway activation as being cut with a knife or something. So you can actually research this yourself, and the studies aren't like muddy. It's actually pretty consistent that the studies show that having good social support and good physical health are actually 1 in 1. So this slide, before I go into it, I just want to know, does anybody know what self-efficacy is? So this was defined in 1977. It was by Bender. That it's basically the expectation in your success in performing certain behaviors will result in the desired outcome. That's a very complex definition, but what that means in colloquial terms is that the pain can't stop me. So if you believe that the pain can't stop you and you don't have fear, it actually can be a positive outcome for not having pain disability. So let me just unload these, but if you have positive self-efficacy and you don't have fear avoidance and you break those cycles with depression and good social support and fear, actually it can be a negative predictive factor for pain disability. And you can have a bigger buffer for other pain episodes in the future. So it can go either way. So if you have negative reinforcement, negative enabling, and pain and you're focusing on your pain and you're catastrophizing is through the roof, it's likely that procedures that I do and other procedures, like let's say you get back surgery or something like that, it's highly likely those procedures won't be successful. So depression's a high risk factor for not being successful for like a spinal cord stimulator. Positive predictive factors include positive reinforcement, having autonomy, so self-efficacy, the pain can't stop me, distraction, doing other things besides staying at home, and having a good buffer with good social support. Just some further benefits from Matos is the same article, is that distraction, other coping skills, the active coping skills is protective factors for pain-related disability. So I did extrapolate some data from the workers' comp world where, you know, only 5% of people, even depression's a big risk factor too for not returning to work. So social support, regardless of your influences health outcomes, regardless of your stress levels. And then perceived promotion of autonomy versus perceived promotion of dependence. So how you view yourself actually influences your outcome. If you view yourself as someone who you can't get through it, the pain stops you, you can't manage, it's highly likely you won't be successful with anything that's done, you know, medications or anything else. It really comes down to psychology. And I'll be honest, I mean, you can tell from my background, I did radiology, I looked at images, a very concrete sort of practice, but coming into this field, it kind of reset my world of seeing how important psychology was. So this is interesting too. So actually pain self-efficacy, believing that the pain can't stop me versus fear, pain intensity was actually a less important outcome for people who had high self-efficacy, where they believe that the pain couldn't stop them. And while social support has many benefits, it does not seem to have negative effects. So can't hurt to have, I guess that's like an academic way of just saying it can't hurt to have friends, can't hurt to have family. I mean, even if they, you know, it's not always positive 100% of the time, but it's always good to have people, even just to talk to. This is like the summary slide. So you have pain. Everyone in this room probably has some sort of pain. Pain is viewed actually, part of it is just part of the human experience. Biology causing the pain, cytokines being released, psychology with, you know, depression, same cytokines can be released, and then your social support. Having a good social support is actually one of the biggest tools you can have. So making the pain the whole pie, you can actually make it just a part of your pie, where maybe you have pain, but it doesn't stop you from doing something you love, like, you know, going out, having a good time, exercising, commuting with friends. And the research is pretty, I mean, it's not too debatable because so many studies have been done that actually having a life in terms of work, hobbies, and exercise and whatnot actually can make your pain scores go low. And even if you rate them higher, it doesn't, the way you view it is not as big of a deal. So put that in, and that's it.